Okay, let's start. Good afternoon, everybody, and welcome to our second webinar in a series of 4 around value-based care. My name is Paddy Markey. I'm the marketing manager for Coloplast Wound and Skin Care, and I'm just going to make some introductions and then we'll facilitate some questions to Christine O'Connor from Pioneer Telehealth at the end of today's session. So as I said, this is the second in a series of 4 webinars. For anybody who has not seen the first, we'll put a link up in the chat because that webinar is available in full on Coloplast Professional if you'd like to view that. And all of the webinars of the series will be available as we complete. So Christine, good afternoon and welcome again.
Hi.
You know, 2 things I took away from last week. One was your terminology around the burning platform. I think you're going to maybe touch on that again. And really useful slides on the NHS infrastructure and how everything's going to work in the world going forward, but also how you're sort of helping explain the whole concept of value-based care and putting into really easy terminology for us. So I'll hand over to you now, and as I said before, we'll take questions at the end of your presentation, so I'll come back on screen. So if you have a question for Christine, on any of the topics discussed, please pop a question into chat and we'll pose those to Christine in about 45 minutes. Okay.
Thanks a lot, Paddy.
Thank
you. So today's session is a really important session in terms of the whole concept of value-based care. And it took me quite a while to piece this together to make it meaningful for everybody. And I'm going to, first of all, want to say a little bit of this is about tough love, because I need you to come to this session with a very open mind and be objective about some of the things that I'm going to say, because it might kind of get under people's skin a little bit, but it meant with good intent. So I want you to really try and get on board with what I'm trying to share with you today, even though it is really the top layer. It's just a quick look at this side of things. And this first slide is really important. And I want you to think about this because you're all very busy people. And that statement about most people do not listen with the intent to understand. They listen with the intent to reply. Now we're going to keep coming back to this because it's really important. And I also think you've got to get into your heads the fact that as clinicians, and I'm assuming mainly clinicians today, that as clinicians, when you're thinking about value-based care, the pivot of this for you is the shift from seeing the highest quantity of patients to actually moving to the thought base around quality care. And I can almost hear you saying now, how the hell do we do that in the world that we work on a day-to-day basis? Can we move to the next slide, please? And I think, as we do that, that's critically important for you to consider. And this I had to put in when I found this slide. Everybody wants to change the world, but nobody wants to change. And if you look at the different iterations that have happened with the NHS over the years, the word change appears in just about everything, all through the different iterations that have happened. And the fact is, everybody thinks it's everybody else that needs to change and not them. And this is about recognizing that it doesn't matter what our job is. All of us need to reflect and think about how we do what we do on a day-to-day basis and recognize that it's not somebody else's responsibility. It is ours. Next slide, please. So today, the things we're going to focus on, if we remember this slide from last week, the things we're focusing on are the 2 aspects of the workforce, you as clinicians, and the patient's experience of care. Thank you. Next slide, please. And I remind you again of this one, and it goes back to that piece about changing. If you change nothing, nothing will change. I don't know how many of you are aware of the BMA meeting that's been taking place this week, but the BMA were being encouraged by GPs to actually take general practice out of PCN world. It's just not going to happen, guys. It's not going to happen. And people have got to realise that we've got to move on. We've got to change, because the capacity we have in the NHS health system and the cost with less capacity is causing us a major problem in terms of what we can deliver on a day-to-day basis. And I'm going to go now to something that you'll recognise. Next slide, please. So for those of you working as clinicians at the coalface, on the front line, whatever you want to call it, sometimes this is your world. You know, you're suffering from burnout. I love that thing, your own inbuilt stress management system. Bang your head here and repeat as necessary. And there's many of you feel that that's the world that you're working in. But the thing is, we've got to get past that, and we've got to not stress, and we've got to think about changing. But sometimes, because you are so entrenched and so concerned about the pressures that you're working in, you don't always think about how you need to think about where the patient is in this. Next slide, please. Because the world in which your patient is living may be just as bad. I'm looking here at this. People who are living with debt, people who have got problems in their homes, people who are hoarders, people who have been constantly rejected. That's their world. So you're living in your stress world, and they are living in their stress world. And the challenge we face is how do we square the circle in those circumstances? Next slide, please. So I bring us back to the piece I said at the beginning. Most people do not listen with the intent to understand. They listen with the intent to reply. And I use the example I used many, many years ago about talking to a patient and saying to this patient, "How are you today, Mrs. Jones?" And Mrs. Jones goes, "Do you know what? I'm really fed up. It's terrible. Okay. And I'm having a terrible time." And you go, "Good, good, very good. Let's get on then." And somehow the response doesn't sink in. And this bit is really, really important. And I'm going to focus now on the quantity quality care thing to start to make the point about what we're saying here. You're sitting there with your stresses and strains. The patient is sitting there with their stresses and strains. And somehow we have to get a line of best fit between those two things. Next slide, please. So your world of the quantity syndrome. So you think about it, you almost are on that conveyor belt of work. You know, if you're working in the community, you're working like an automaton with set units that you've got to deliver. I mean, I don't fully understand how that works because I find it very difficult to actually get the concept in my head that if you're with a patient, if you've not done it in 15 minutes and got out the door, somebody at the other end is going to lose out. So I think there's something about understanding that we have a conveyor belt way of working, and that's not anybody's fault as individuals. That's the environment we've been forced into. And I think this phrase here is really interesting. What changes people's opinions? It's not leaflets, it's not media coverage, it's not even going viral, it's human interaction. It's that thing that happens between two people that changes people's opinions, and that's critically important. So we move then from the quantity syndrome, next slide please, to the quality route. Okay, we move from that, we look at communication, the interaction is important, and we move to collaboration. This is the direction of travel. This slide is really important, guys. I really need you to think about this. And I want to introduce you to those of you who've not heard about it or don't know much about it, to motivational interviewing, which is a technique that I introduced with nurses when I was working at Accelerate. And I think it's one of the most important pieces to help us move forward in building that collaborative relationship that needs to exist between a clinician and empowering citizens. Otherwise, we will never make it in that world. And there are 4 guiding principles to patients' motivational interviewing. The first one is resist the writing reflex. What that means is resist correcting all the time. Resist that sort of thing all the time. And understand the patient's own motivations. Listen with empathy and empower the patient. If you don't understand the patient's motivations, how can you possibly go on the journey together to actually begin to actually get a solution to what needs to happen out there. So I will implore you to think about this particular side. And if you haven't done anything around motivational interviewing, you don't know much about it, I would ask you to have a look at it, because it's really important. Interestingly enough, when I first introduced this, most of the nurses said to me, I haven't got time for this. I haven't got the time. I can't spend time chatting and doing. And my response to that was, you haven't got time not to. Because unless we change how we operate with some of our patients, then we are never, ever going to get out of that ongoing vicious cycle of having to keep seeing people all the time and just doing all same old, same old. Next slide, please. So next question is, do we both want the same outcome? I'm talking about clinician and patient now. So how can we define these outcomes we're looking at? It may well be for you as a clinician, you will be looking for an outcome that's really around treatment or an intervention, and it's quantitative. So you're looking at, what's the healing rate going to be? What's the healing trajectory? That's the bit you're in. You want to heal the wound wherever it is. I'll work with lower limb because I love talking about lower limbs. So you know, how am I going to heal that wound? That's my job to do that. What's the patient's desired state as a result of experience of treatment or intervention? What do they want to get out of that? And that's qualitative. That's not quantitative. That is qualitative. And there's something about understanding what that means in the real world. Okay, so what I mean is, how do we get to a balanced shared decision making so that those two things are met on that healing trajectory, if you like? Whoever's put their hand up there, can we take that question as we go towards the end, please? So I think understanding what the patient's desired state, it could well be, do you know what? I'm thinking about a lymphedema patient in a minute. I want to be able to wear nice shoes. I want to be able to walk down to the park with my grandchildren. I want to be able to wear nice clothes again. I want to go out and feel like I haven't got a smelly leg ulcer. I want to feel like me again. And the nursing side of things is much more about, I want to heal. I believe that to be the case. And I'm going to talk about healing and management a little bit further on. So what I'm looking at here as a solution is the balanced shared decision making. That should be our way forward. Move the next slide, please. So this is an interesting one, isn't it? And I put this in deliberately because we often live in a world of blame culture, don't we, as well? And that's why we've got, it's not my end of the boat that's sinking, it's yours. And so when things don't go right, we go, well, do you know what? Well, I've got a non-compliant patient. They're not concordant. These terrible words that we use, or, you know, if it wasn't for the fact that so-and-so did this, I'd be able to do that. And some of those challenges are caused because we can't deliver consistency always. One nurse will go and do it one way, another nurse will go and do it another way. And then you actually get a divergence of thought processes, possibly with mixed messages being delivered to the patient. Sometimes it isn't the patient's fault. Remember that slide with the world that they're living in. There may be other reasons why they can't do what you want them to do. And there's something about us all rowing the boat in the same direction. You know, if you're in a big rowboat and somebody's rowing the wrong way, you're not going to win, are you? You're going to go wrong. So there's something about that too. And in all of this, it's not about being a superhero. It's not about that. It's about actually recognizing, how do we move forward differently to how we're working now? And I'm going to move on to a slide now, which I've stolen from an NHS document. Next slide, please. And I'd advise you to have a little look at this too. So this is about personalised care. Now, I could do a whole webinar for you on personalised care, but let me just draw your attention to this. So this is about, how do we do things differently? How do we get to shared decision making? And how does that work with the general population against how it works with people who've got long-term illnesses, long life conditions that maybe need to work differently. And then how do we use different resources in the NHS or in social care to actually work with us to work differently with those patients? And that includes primary care. The primary care network structure is meant to be structured to enable this to move forward. So this is really important, and it's critically important that we move towards enabling people to have more autonomy over their own health, moving away from the doer. I'm not going to do this to you anymore. We are going to agree together how this is going to happen, and you're going to play your part. Okay, so it's about shared decision making at an individual level and shared surface planning at a population level. And I can almost hear some of you saying, well, we don't understand the population health side of things, but we will get to that next week, which will help us move on that side of things. So I move again, I brought in again another slide from last week. Next slide, please, which says that you're not on your own with this. This is not about doing it alone. You're back in the rowboat. There's teams of you need to do this. You need to talk, share, you need to connect. And again, you need to remember that that you can only do this together. You cannot do this on your own. You'll be a lone voice, and somebody will shout you down somewhere and go, God, blimey, what have they been on? Have they had too much alcohol or been smoking a spliff or what? Because they're kind of just, what on earth are they going on about? But we've got to start somewhere, and we've got to start connecting. And sometimes your PCN world is a great start point for you. Next slide, please. So this slide here is, I stole this from an organization in America, actually, where they call it patient-centered medical home. And I felt when I looked at it, it told me a lot around what a primary care network should work like. And this is about primary care at scale. And this is also about not just GPs in isolation. This is about, whilst the primary care physician has an important role to play, it's the team of people that are around that individual that actually enhance the patient experience and the patient engagement in the whole new world that we're moving into at the end of this week. Let me remind you, ICS is in place at the end of this week, so things start to move differently. So I think, again, have a little look at this and see where that helps you move forward. And again, last week I said I was going to touch on the social determinants of health. Next slide, please. Remember, we talked at the end, towards the end of last week, talking about clinical care having 20% impact on health outcome. I know that feels a bit shocking to hear, but what we've got to recognise now, that medical care is not enough for getting to better health outcomes. All of these other things impact. Health behaviours 30%, socioeconomic factors 40%, physical environment 10%. So everything about your individual life actually affects how well your clinical outcome is likely to happen for you. And that's why we start to see these diverse roles starting to come into the world that we work in. That whole idea of trying to move to prevention and early intervention, as opposed to wait till it gets to the point where, it's actually not doing very well, then we'll do something. I find it interesting myself to consider that you wait 6 weeks before you refer to a specialist for what might have been the simple pretibial laceration. Left 6 weeks is almost moving towards being an ulcer, and then you've got into problems. And why aren't we doing something earlier to start to deal with these things, to help them work more effectively? All this is about value-based care. The concept of patient activation, understanding a patient's ability to self-manage. For those of you who've not been exposed to the concept of patient activation measures, it operates at 4 levels. Level 1 is a patient who's least able to self-manage. And in those circumstances, you think about when you've got the patient sitting in front of you and you start saying, so when you go home today, Mrs. Jones, I want you to remember to, manage your legs carefully, make sure you cream and wash them well. Remember what I said to you about how you use your wrap. Remember to do this, remember to do that. And poor old Mrs. Jones is overwhelmed and remembers one thing that you asked her to do and comes back and hasn't done the other 4. So a person with low activation needs to be asked to do one thing and one thing alone. And if they struggle with the one thing, you've got to ask them why. What stopped them doing that? The importance of coaching is in there, and that links directly with social prescribing. So that if stopping somebody moving well with their health care is about the world, is about the damp in their room, is about the fact that they're a hoarder, is about the fact that they've been out of work and they've no money. All of these things play a role in understanding where you can go with this. So there's a whole concept out there of signposting to move people into being able to deal with that challenging environment in which they find themselves. It's very easy for those of us who are relatively healthy to sit and comment about what it must be like for people who are really struggling in the lower end of the income bracket, to actually, when you ask them to do A, B and C, for them to think that's a priority in their world, because it may well not be, which is why that shared decision making and how you come together to understand what the goal is critical going forward. And the next slide, please. Okay, the elephant, I've called this the elephant in the room because I think it is. Because everywhere I look at things, we talk about managing wounds. We don't talk about healing wounds, we talk about managing them. And certainly in my experience, if there is an element of swelling in there, we call it lymphedema, because then we don't deal with it, even if there's an ulcer there as well. So my question is, which business are we in? What are we there to do? Are we there to just simply manage, which is an expensive business to be in, guys? It's really expensive, because if we are simply managing, then on a regular basis, we are going in, nothing's changing, we're bandaging, we're doing whatever we're doing, and that goes on ad infinitum. I think about when I would say to some of the nurses I've worked with back when I was back at Accelerate, how long has this patient been coming to us? And why are they still here? What have we not done? Why are we still having somebody with a non-healing wound still coming back to us 12, 18 months beyond when we first saw them? Because something's not right if that's the case, and the cost base is high. But if our business is healing wounds, and if there's a swelling, we call it maybe lymphovenous or chronic edema, and we deal with it in totality, then we are moving into the world of value-based care, and we start to share the way we're trying to do things with the patient, so that we've got a shared goal, which is to heal the wound in a certain amount of time and to make sure that that patient reaches their goal, which is whatever, walk in the park, going out, able to move around better. But there's a joint goal that you're heading for, and that takes us into a whole different place of how we measure value-based care. So you notice when I'm talking about value-based care, I'm not talking about how do we do the cheapest possible option. I'm talking about how do we change how we work. Next slide, please. So value-based care. So I'm just going to go on a little bit of a journey here, if we can, to try and understand what this means. So value-based care, our overarching objective is to help the patient stay healthy and prevent recurrence. That's what we're trying to do, trying to get them better and help it not happen again, or if it does, help them understand what to do when it does. That results in a better patient experience. It improves productivity because in the longer run, you reduce the time that you're spending with the patient, and per se then that reduces costs because you're not using as much product, You're not having to spend as many days, so you're not 3 times a week or whatever. You reduce all that, and that results in a great job. So the question is, how do we do this? Okay, next slide, please. Busy slide, but important. So the key, all I've done in this is to kind of put down the key elements of the approach as I see it. Okay, this is my interpretation. You may have a different perspective on it, but to be successful, it requires following the right routines. You can call it a pathway, whatever, but this is where I'm coming from with it. First of all, you need to understand your patient population or your caseload. And I'll talk more about that next week, because that is really important. Because if you understand your caseload, you begin to understand what the data is telling you. What data have you got? If you haven't got any at all, go and ask what data exists. And then there is a need to stratify that population you work with, because it will stratify into those very complex cases where you're looking at non-healing wounds, to those that are sitting in the middle bracket that are kind of bobbing along and you need to move them out, and to those people who potentially are at risk of moving into this area and need a different level of care. You need to understand patients that you may have been seeing forever. I don't know whether you have or whether you haven't, but I know in many places that I go to, there are those patients. Why are you doing that? And what are you going to do to change that? Because that's really important to move those patients on. You know, I think about somebody saying to me the other day, we've got a patient, we've been seeing her now for 3 years. Why? Because the patient is used to that environment and used to just something happening, going away, and where's the progress in that? So you've got to be clear about your goal with a patient and setting the timeline to the achievement of that goal. So you need to set your own goal, and certainly the National Wound Care Strategy has got markers in the sand, pinch points as to when you should be looking at the measurement of the wound and its progression. So there are standards there to start to get your head around, to follow. So if you're saying we want to aim to have healed this in 24 weeks, I'm taking a random number there, and poor old Mrs. Smith wants to be able to go out and have a nice time and go out to dinner in 24 weeks time, then you've got a shared goal and you're going to go on that journey together. So that means you also need to be clear on the patient's goal. What does the patient want and hope for? And you go on that journey together with the shared goals. And I've written there, that is not cheesy. It is not a cheesy statement. It is reality about that journey together, because you've owned something that you're doing and the patient is owned. You've got to get the patient owning that journey and owning the success with you. You need to try and walk away from those accusatory words that are regularly used out there. Like the number of times I hear people say, but the patient is non-compliant. But does the patient really understand what it is they need to do and how they need to do it? I'll give you the example of how hard it is for somebody to use a wrap. I've got it further down there, but it's easy. You guys know how to use a wrap. You do it all the time. But when that patient is away from you, to get the level of compression, that is not easy to do. And it often stands in the way of moving forward successfully. So you've got to be clear, again, going back to the activation, on a patient's confidence and skill to self-manage. Don't have your expectation too high. A level 3 is a real self-manager. This is somebody who wants to take away the responsibility, wants to do more. And you will have different levels of people within your caseloads hitting the way that they can actually manage or not manage. And it's the ones that can't that need a bit more of your time, to be honest. So that really is a critical piece of understanding that, if you can. And I go back to that reps and a good story for it. You know, I think about all the reps that have came in to see me and went, oh, this is really easy to use. You just get the patient to pull this over to this level. And when it reaches that colour, then you know you've got the right compression. Okay, yeah, okay, that's all right telling me that. But you tell somebody else that who's absolutely overwhelmed with what's going on in their lives, and they won't even remember what you asked them to do. And then they'll find it a faff and they won't do it. You know, so you've got to think about these things. The objective here then is to get the patient on a prevention trajectory. So this is all critical in value-based care. You get on the prevention trajectory, the patient understands what triggers will cause them to go off and start things going downhill again. And that's the point at which something needs to go into place to stop that happening again. And that's maybe where primary care comes into place and primary care nursing to actually be able to deal with it early on before it starts to deteriorate again. So the issue of a patient staying well shifts from you as the clinician to the patient. Okay, it's their responsibility to stay well. It's not your responsibility to make them stay well. That sits in their ballpark. By following a route of this nature, then what we start to do is release time, we reduce the use of dressings, we minimize the likelihood of that patient at some point defaulting to go to the hospital. And these are the basic principles of value-based care. And I think that is really, really important in terms of the day-to-day piece. Next slide, please. So I can imagine I've put that tearing your hair bit out there because some of you are probably thinking, you know, this is crazy stuff. I haven't got the time to even do this. But you need to find it, guys. You need to start thinking differently. Don't panic about it because you're in a position where you can start to do something differently, but don't wait for somebody to give you permission. Start to create it, start to look at things, start to think differently and give yourself some breathing space around this, because if you start to do it, then it actually will start to change your working life. But you've got to have it in your heart with a determination to say, I want to do this differently. I don't want to keep doing. I cannot tell you the number of community nurses who find that their life is awful around managing leg ulcers because all they do is stick a bandage on. Nothing happens, and it's demotivating. Through this route, we start to see things happen, things change, things move on, and it gets exciting because you get results. Results excite us all. Doesn't matter what the result is. You know, it could have been result of watching the tennis last night and Serena Williams not winning. Could have been a great thing for some people last night. They would have been way whoopee-doo. But everything that is a result that we're looking for makes us feel good and makes us feel better. Next slide, please. So I come back almost to where I started. Is that everybody wants to change the world, but nobody wants to change. The 1st of July is a watershed day for the NHS. There is a huge agenda of change that's sitting there, and none of it can happen without the commitment and the drive of clinicians. Managers, people like me, can sit wherever we sit and talk about what needs to happen, can write strategies forever and a day, but unless it's embraced by the clinicians, the people that are interfacing with the patients on a day-to-day basis, nothing will happen. You are the key people to making this new world of the NHS a reality, and it's important not just for the patient, but it's important for you. Because the challenges that we face within the NHS are not going away, and the principles of value-based care help us move towards a different thought process, a different way of doing things, and a different way of working with patients. I was speaking with a PCN this morning, and they were talking about the practices that make up their PCN, and there was one particular practice they said was, you know, I don't think I'd really always want to have to deal with their patients because they're really difficult. I'm not sure I'd want to have to do that. Well, actually, if you have really difficult patients, then maybe it's not a medical person who should be seeing that patient. Maybe that patient needs to be seen by a coach, by a social prescriber, to have a very different conversation to allow them to become receptive to what has to happen around their healthcare. So again, I offer it to you. Everybody has to think about wanting to change and not believe it's somebody else's job in all of this. So, final slide, please. So I've talked extensively now today about the clinician-patient relationship and about what that means in reality for value-based care. We put the icing on the cake next week when we talk about population health and well-being. And in case some of you aren't aware, there is a huge amount of work going on around population health management across ICSs, in commissioning support units. So there is data there. But next week, I'll show you a slightly different way of looking at this if you can't access the data you need to get hold of. But for me, I've finished today's session for you. I've done what I think it's 35 minutes, 40 minutes, Paddy, but I'm happy to take any questions now.
Thank you, Christine. As always, very thought-provoking. I have a few questions that I wanted to ask, and just to give people an opportunity, if they have a question, to pop it in the chat function. But you mentioned about motivational interviewing, and we've all heard stories of those non-healing wounds that have been on people's caseloads for a long time. Are there any sort of additional sources of information, references, papers that you could recommend for people to read up on this topic? Because
I will source that and let you know, Paddy,
so
and give people some drive. The one thing I will say to people is, you know, where you've been seeing patients for a long time like that, an opening gambit question is, why do you keep coming? Why do you keep coming here? What you're hoping to achieve? And that opens a whole different world of conversation then. And it's a very ordinary question to ask. Why do you keep coming? And I think that's the useful opener to get onto that kind of conversation. But I'll happily pull a one-pager together for you, Paddy, on motivational interviewing with a reference that the delegates can have.
Yeah, no, you've probably answered the question there, and just it's a very simple, open question, isn't it? To try and establish what the goal of the patient is, what do they want?
Absolutely simple.
But my other question was, I know we've talked a lot about obviously value-based care and transforming and changing, but how aware are senior management within the NHS in this world of metrics and targets? Are they bought into the whole concept of value-based care, or are we just at the beginning of a journey?
I think we're at the beginning of a journey. I do, honestly. I think value-based care has been talked about a lot. I think that whole concept of how those component parts of it sit together is really important. The role of the clinician, the role of the patient, the concept of the population health management, that's value-based care. When you pull all those together, that's value-based care. And certainly at the highest level, the ICSs are tasked with bringing that through place. If people go back to their diagram that I used last week, bring it into place where that's where the rubber hits the road, if you like, and things need to happen. And without, I sound like a broken record when I do this, but you know, without data, we can't do anything. People need to know their data. They need to know their population. They need to know, are there any decent healing rates there? I know for a fact across wound care in general, there's not enough data, but we've got to start measuring that. And unless you get into that joint relationship with the patient and say, my goal is I want to be at this place in this number of weeks, then it becomes hard to do it. But data's key here. Yeah.
Absolutely. Another question that sort of sprung to my mind about is mainly a mixture of terminologies. I know when ideas like this start evolving, there's lots of different words and descriptors that evolve over time. So empowering the patient, and that sort of leans into supported self-care, self-management. But one area that sort of sprung to mind was, what's your view on the emergence of virtual wards? And are they more NHS procurement driven or price orientated, or meeting the needs or empowering the patient?
Okay. Oh, that's a bit of a hot potato there, Paddy. Virtual wards. So for those of you who are long in the tooth like me, will remember virtual wards a long time ago when we tried to bring them in a long time ago. The whole concept of virtual wards, let's go back to what we were talking about last week, is the virtual wards is about taking people out of the hospital setting. We all know that if a patient is in hospital too long, they get sick. They don't get well, they get sick because they get other things as well. So the idea is minimize the amount of time in a hospital, but have a structure outside called a virtual ward. You could call it something else if you wanted, whereby that patient gets better managed in an outpatient setting. That doesn't mean to say we're interpreting that correctly, Paddy. So I might go to one part of the country who's got an interpretation of what a virtual ward is like. I might go to another and it might be very different. The whole concept is taking the ward out of the hospital into the home setting and putting the infrastructure in to enable that patient to get better sooner. The biggest challenge you face, of course, is finding a way of getting the patient out of the hospital into the home setting, because a lot of these patients live alone.
Yeah.
So the actual package you put around them is really important. It should release resources. It should save money. But it also means that if you haven't got the infrastructure in the out of hospital setting, in community and primary care, how do you do it? Because the money's sitting over here and you need it here. And that's why people need to understand the amount of money that is going into the primary care network agenda and how that can be used differently. That's the whole point of new roles and responsibilities and that money that's been allocated into primary care networks to deliver that.
Yeah.
And that's really important that people understand what that is. And I'm quite happy if people need me to talk about that a bit more at the end, and the last one, I'm happy to cover that so that people understand it.
Yeah. But as you say, Christine, this is not a question of just throwing money at the problem. It is about fundamentally changing the way things are working.
It is. That's at the heart of this, Paddy.
Yeah.
Do you know, and you know, I've said this before, and I sometimes think I'll get lynched if I keep saying this. At the end of the day, I could put a dressing on somebody's leg and it could be the cheapest dressing I can get my hands on, all right, because that's what I've been told to do. That patient's time to healing could be extended beyond a number of weeks because I haven't chosen something that's better, something that's known, something that may cost more, but in the end will cost less. I remember this from when I was a product manager. Believe it or not, I did work in the industry at one time, and I was responsible for an antibiotic. And I remember talking to a GP and the GP saying to me, oh, well, we have a process for this. If somebody comes in with a chest infection, we always give them 250 milligrams of amoxicillin first. If that doesn't work, we give them 500 milligrams of amoxicillin. And if that doesn't work, we then give them a stronger antibiotic. So my question was always, one, how much have you just cost the NHS? How much have you just cost the patient in still feeling ill and getting worse? And how much have you encouraged the growth of flora in there that shouldn't be there because you've overdosed on antibiotic? Because if it doesn't work, it sits lovely in there and gets lovely and warm and makes more bacteria. And this, I can't get my head around why people go, well, we'll try that. And if that doesn't work, we'll try this. Go straight to the best thing. Use the best thing, cost less in the long run, get the result. That's what you want as a clinician. That's what the patient wants.
Yeah. Great. I'm just going to go a few questions. So Lauren has asked about, I think we've covered this one, about motivational interviewing and any suggestions of sources for training. So I think we will source those for you, Lauren, and make sure you get hold of the right references and further reading.
Can I just say something on it though, Paddy? You know,
yes.
All I'll say to you guys about motivational interviewing, when it works, when you see it in action, it's life-changing for you as a clinician, because you're not on a one-way street anymore, and you start seeing something happening, and you start to get to know somebody better, and it works more effectively. I'm not saying, you know, you got to have a hug every time you see somebody. What I'm trying to say is it changes the nature of the relationship.
Yeah. One other area that I was asked, I've written down, Christine, is just about, you know, I really like the idea of the patient activation measures and the 4 levels. Is that, again, people can access that information? It's freely available if they... So
there is a system that was purchased by the NHS England some time ago from a company called Insignia. And it was patient activation is measured using an algorithm. You ask 13 questions, and you know, the cynics used to say, oh, well, the patient will skew the answer, but the algorithm was built in such a way that they couldn't. So it actually gave, when you put all the answers in, it spewed out the activation level for the patient. But I'll happily give people some context on some information around patient activation, because it's really, and that's another really interesting area. And all I would say to people at this stage, remember, if you think somebody's a 1, they can't self-manage, they're not engaged, don't give them loads of things to do. If they're like really G'd up and excited about the potential of getting, then they're a 3. They're maybe nearer a 3. Challenge them a bit more. But if people can't do things, get them to make notes to bring back to you about why they struggled to do what you asked them to do. But stop using those awful words like non-concordant, non-compliant. Get rid. Okay.
And I've got a question or a comment from Honey, which thank you for your comment. She's inspired by the seminar. And I'll read it out because you might not see it, Christine. So, considering that complex care models are adapted in the UK, how can private companies employing HCAs or senior carers working closely with immobile patients strengthen the linkages with community nursing to prevent and manage SORs? And will there be a framework for that going forward?
Interesting. So the interesting thing about private companies there is about how they start to interface with the provider collaborative, really, to get their head above the parapet, and how they start to talk to people about what they can bring to the agenda and how they can enhance it. I think that's the important thing. This is anybody's game now, Paddy. It's anybody's game to get to but you've got to get to the table, and you've got to understand who are the movers and shakers and how you do that. So it doesn't matter whether you're embedded in the NHS or a private organisation. The private organisation has got to absolutely be able to describe what advantages they can bring to creating that value-based approach.
Yeah, I guess it goes back to the graphic you showed last week about the NHS infrastructure and the sort of 6 rings of how it's all going to sort of net together between the provider, place-based partnerships, and the ICS. So that's probably a good starting point as to who are the right people to talk to.
The one thing I would always say to people is, and I said this to somebody the other day, the ICS is a very strategic body. It's up here. It's dealing with the population of 2 million, and you're a little voice. So find the best place for your little voice to become a big voice. And that's somewhere in place-based care. That's where you've got to, don't try and reach the higher echelons. Move up, and suddenly they'll start to hear what you're doing, and do something. Don't just sit there, do something, because the message will rise.
Yes, the cream rises to the top.
Absolutely, Paddy, 100%.
Jamel, thank you for your comment, because she's saying she's using motivational interviewing across the board from consultant level to specialist nurse. So it's great to see that. So there's examples of it already in practice.
Brilliant, brilliant.
If there's any more questions, I have one. I'm probably stealing the ground here, but one more question for you, Christine, is, and you touched on it in your sort of flow chart, but how are we going to prove delivery of value-based care?
Right, so that's I'm going to touch on next week.
Okay, so that leads nicely into...
I had to get a balanced thing today, because I could really have wandered into next week's topic, and I don't want to do that, because I want to be able to show how it all sits together. And so we've got to get a little plan. And I think I think once we finish this, there's a way in which your organisation, Paddy, could reach some of these people to support them in walking through the process.
Okay, well, that's probably the perfect opportunity to close off, if we don't have any more questions. To thank you again, Christine, for another thought-provoking and inspiring presentation. And again, all of these webinars will sit on Coloplast Professional. And again, we have next week, we will be exploring the next phase of the series. So Christine, thank you again.
Thank you all.
Enjoy the rest of your day, and we shall speak soon.
Cheers. Thanks, Paddy. Bye-bye now.